Well, good morning, everybody. I'm Fred Myers. As my friend Dr. MacMillian says, I'm the Hospice Medical Director Emeritus here at UC Davis. I'm the Chair of the Department of Medicine Emeritus. I'm the Chief of Hem-Onc Emeritus. End-of-life care. So it's really great to see all of you here today. It's really been overwhelming to see such a great response from our community to join us today in what we think will be an important conversation. Just the usual housekeeping. If you could turn off your cell phones and other devices, that would be really helpful. You have index cards where you're seated, and we'd like to use those index cards for questions at the panel later in the morning. We'll have time for questions and answers after our speakers is the first part. One of the nice things about palliative care is that it's really about telling stories. And one of the really highlights of my career has been to make house calls all over the Sacramento region, up into the foothills, and really understand the stories that patients and their families have to tell. And as you know, a lot of this palliative care topics have as much to do with families, however we define our families, whether it's a traditional family or individuals who live downtown in single-room hotels. We define family so diversely here in California and in our nation and many of you represent those families. So it's really been an honor for me to understand the stories that people tell during their lives, and much less about dying, but much more about living. I'll be your Oprah today. I'll be your Ellen DeGeneres. I'll be your Michael Strahan. Someone stop me when I get to the right one. It's a pleasure to be able to MC what I think is a really fun morning to really interchange with you and with our distinguished panel. The panel comes from very diverse backgrounds. We have physicians and nurses, people of spiritual background, volunteers, social workers, and isn't that the essence of what we're role modeling in palliative care in this country, and particularly in this community, a community that has really been on the lead of that. And what I have found interesting over the last few years is that, we think about palliative care as the relief of or the anticipation of emotional or physical suffering delivered by an interdisciplinary team focused on the patient and his or her family, again broadly defined. And again, not necessarily just at end of life, but at any time there might be emotional or physical suffering. And we see that in our society, and we certainly see it during times of threats to our wellness and during illness. So what a great way to think about palliative care in that holistic way. I think all of you know that the rest of society and the rest of the healthcare system has said, wait a minute, when you look at patient satisfaction surveys, who's always number one? It's the palliative care team. It's the hospice team. Why is that? I think it's because we together think about goal-oriented care. We think about how we deliver care across the continuum from hospital to clinic to home. We think about what's important to patients and their families. Patient family-centered care. These are all the precepts of quality of care, of value. It's not about end of life. It's not just about palliative care. We are role modeling best quality care in this country. And that revolution started in the 1980s and early 1990s. And now the rest of the country is looking to develop care programs, which frankly, when I go places, I say, yeah, that sounds just like palliative care. It's patient family-centered care. It's goals of care. It's best quality care. It's timely access. It's equitable care. Everybody gets palliative care. We don't discriminate against people. Everybody gets timely access. It's safe care. It's efficient and effective care. And it's all done in a way that drives the value of health care. So I think it's been very interesting over the last couple of decades, and we're only in the second or third generation really in this country of palliative care. and you all at the leading edge of that. So it's a pleasure to welcome you and set the stage for, I think, will be a very, very interesting, interactive, engaging morning. So we're going to have our first speaker, and to introduce the first speaker, I'm going to introduce one of our palliative care fellows, Dr. George Gallardo.
All right, good morning. So my name is George Gallardo. I'm one of the hospice and palliative medicine fellows here at UC Davis. And this morning, I have the honor of introducing my friend and mentor, Dr. Jack MacMillian. Dr. MacMillian is a clinical professor of medicine here at UC Davis. He's also the UC Davis Hospice Medical Director, and he's also the Fellowship Director for the UC Davis Palliative and Hospice Fellowship, so he's my boss. And he is board certified in both internal medicine and hospice and palliative medicine. So with that, I'd like to introduce Dr. Jack MacMillian.
Yeah. Thanks, George. Those are the nicest words I think he's ever said in the past year to me. So thank God he doesn't graduate till next week, so I still have to decide to sign his certificate. So still waiting on that. Again, I want to welcome you all here this morning. I remember sitting down and planning for this. We were throwing out ideas about what our topic should be, and I said, oh, you know what? We should give a talk about dispelling the myths of palliative care. And Annie goes, that's great. Jack, you're it. So just like in Annie's, nice way. So this is what we're going to spend probably the next 20 minutes ago talking about dispelling the myths of and misconceptions around palliative care and also hospice care. So I have no financial relationships to disclose to anyone. I work for the university. So a couple objectives here is I think hopefully walking away to make sure we're all on the same page about what does palliative care really mean. I think there's a lot of different definitions out there. You talk to physicians, and if I sample 10 different physicians, I'll probably get 11 different answers because some physicians have 2. Dr. Myers. We're going to hopefully explain the difference between palliative care and hospice and where do they fall on the continuum of care. Demonstrate how palliative care can be integrated in the lives of all of our patients and those living with chronic illness. And last, debunking the myth that palliative care and hospice are about giving up, which is probably the number one conversation I think many of my palliative care colleagues and I have with our patients and families. So I was thinking about the top 10 list originally with David Letterman, but then they cut me to 20 minutes, so I had to go to the top 5 list here. So we're going to start with number 1. Palliative care is only for patients at the end of life. Again, I think this is a common misconception. I think what I want to do in the next couple slides and help us is let's standardize some definitions. Let's all walk away and know exactly what we're talking about with palliative care. I'm here to tell you that, again, this is not true. So a couple definitions. So as a doctor, I'm a pretty simple man. The fellows will tell you this. I'm a man who believes in buckets. I always put everything into 1, 2, or 3 buckets. I like to make things simple, take the big view, overview, and then we'll work to the details. So when I think about medical care and medical treatments, I think about them in 2 big buckets. What we call disease-directed therapies. Those are treatments that are designed to either cure your illness. So if you have a pneumonia, I'm going to give you antibiotics, and hopefully I'll cure you, and that's my disease-directed treatment. But if you have a chronic illness, I may not be able to cure it. But my goal is to give you treatments that actually improve the quality of your life, slow down the progression of that illness, help you to live as long as you can, if that's your goal. So that's disease-directed therapy. So if you're a cancer patient, that's your chemotherapy. That may be your radiation. If you're a congestive heart failure patient, it's what we call your diuretics and all your other medicines to help your heart. So the other bucket of treatments are what we call symptom-directed treatments. They're aimed at controlling your symptoms that your illness creates. Nausea, pain. It's also about improving the quality of your life. And in those symptom-directed treatments, a lot of those, the psychosocial family aspects come into our treatments. Because we recognize with chronic illness with patients, it affects their entire family. So a lot of times when we talk about improving quality of life and controlling symptoms, people often refer to that as comfort care. I don't like that term comfort care because I think it carries certain connotations, but from a palliative care perspective, when I say comfort care, I'm purely talking about improving the quality of your life and controlling your symptoms. So a definition for palliative care that I like, it's an approach to treatment for patients who are dealing with chronic, progressive illness and or life-threatening illness. The key components is, if you look at these key components of what we do in palliative care, it's exactly what Dr. Myers was just outlining. If you look at all of these things here, you'll say, man, that sounds like good medical care, right? That just isn't palliative care. That's high-quality care. Patients want their symptoms controlled because if your symptoms are controlled, you feel better. Number two is, I want as much quality of a life as I can while I'm living with my illness. As we know in medicine, we may not cure a lot of things, but we've gotten very good at taking illnesses and making them very chronic, and people can live quality of life with their illness. You know, when I first started, I'll tell you, when I first started training in the 90s, I was in Philadelphia. I remember HIV patients coming in and taking care of them, and they would come in and be admitted and die in 6 weeks. There's nothing we could do. And now here I am 20 years later, 23 years later. HIV has become a chronic illness. And they're living normal lives and they're dying of what we call their age-related illness. So medicine is an amazing thing about how we've changed the course of illnesses, but we don't cure it a lot of times. One of the big things we do in palliative care, and my next slide will reflect this, is how do we tie in our medical treatments to what we call the goals of care that patients have. And it's an interesting thing when we start talking with patients, when I ask them, what are you looking for from your medical care? And a lot of times, it's almost, when I ask that question, it's almost like when you look at your dog and your dog kind of turns their head. Because I think a lot of times we haven't stopped and asked ourselves, what am I really looking for in my medical care? And they often say, well, I want to live as long as I can. You know, and we start to explore other options and other things about the aspects of their lives, about their family, about work, about their symptoms, about their fears. And we actually can then begin to develop what really is important to them. And then what we do in medicine is say, these are my treatments that are going to help you accomplish these things, rather than the other way around where I just start throwing treatments at you and hopefully at the end you feel better or we accomplish something. So it's a very different approach. It is about supporting the family because, again, as I said, illness affects the whole family. So how is your family dealing with this? Are there things we can aim at providing support to your family to help provide better care for you? The other big thing is, and the next slide will get to this, is about the timing. Timing of care. Where should that care be? Should it be at home? Should it be in the hospital? When should we do certain treatments? When should we stop doing certain treatments? That's really about creating a roadmap for patients and families as they go on in their illness. So the first two slides kind of bring us to this. Again, I'm a big picture guy. I think pictures speak 1,000 words. So just to go over this diagram, and my palliative care colleagues have all seen this diagram. Over here on the left, you get diagnosed with some illness. And let me over here. And we introduce some treatment. At the beginning, a lot of times with diagnosis, you may have a little symptom burden. So palliative care has a small component in what we call your disease-directed care. But as time goes on, your disease progresses. We know our treatments become a little more invasive, a little more aggressive. The risk-benefit, we always talk about risk-benefit ratio when we're talking with patients. This is the benefit I'm hoping to get, but this is the risk. You're going to have to endure the side effects, the commitment to coming to the hospital, the commitment coming to the clinic that you're going to have to endure for your treatments. That becomes greater and greater, so patient symptom burdens become greater. So palliative care increases its role or need for patients as they go on, and eventually at a certain point, our disease-directed therapy no longer is probably an option for many patients, or it isn't going to help them accomplish their goals. At that point, predominant of their illness is palliative care needs. And then at a certain point, when patients enter, we consider hospice is when their disease is estimated to have a 6-month prognosis. And as doctors, I'll share with you, we're not very good at that, you know. And we'll talk a little bit about that later. But again, if you're in that time frame, that's when we consider talking about hospice, and is it consistent with the goals of care that you may have? And it may not be. So, myth number 4. Hospice care is the same as palliative care. So, as you see, if you go back to this slide, they're really not. Again, I tried to lay out this as a continuum of care. And hospice kind of is a natural extension of palliative care. If you look, though, hospice and palliative care, number one, doctors think they're the same thing. Many of my colleagues do, and we spend a lot of time educating doctors. They're not the same thing. And if you walk away with one thing today, just recognize palliative care and hospice are different. They overlap and share a lot of things in similarities. Focus on quality of life, addressing the psychosocial, spiritual needs, physical aspects of illness. But you can see palliative care can be delivered along with what we call disease-directed therapy. You're still getting chemotherapy for your cancer. You're still getting congestive heart failure therapy. You're still going with your COPD therapy, whatever your illness is. Often in hospice care, at a certain point, we say you've made the transition and we're going to focus in on what we call comfort care only. You're going to be aggressive in your symptom management, but it's about quality of life. It's no longer a lot of times about quantity of life at that point in time. So again, a little less disease-directed therapy. So they're on a continuum. So myth number 3, palliative care is only for cancer patients. Again, that's where it first started. Delivery in this country, hospice first started actually by the initiative of the National Cancer Institute. Palliative care for a lot of our patients is viewed as is for cancer patients, but it's not. Let me share it with you. Again, I told you I'm a picture guy. I think it's easy to explain. When I think about patients and their medical illnesses, they kind of fall into one of these 4 categories. Up on the upper left, patients have acute illness. They're doing well, they're in their usual state of health, and something tragic happens. This is a motor vehicle accident. This is a sudden heart attack. This is a sudden stroke. And patients will not survive. That's 10% of patients. There's really very little role for palliative care in this setting because the acute illness is so quick. But when we think about these other 3 things, in the upper corner of this terminal illness, this is often cancer. This is cancer trajectory in our Medicare patient population when you look at this database. Patients are doing well, and all of a sudden they'll get a cancer in older age, and a lot of times the therapies may not be as effective. And the time between time of diagnosis and time of patients passing away is a very short time. It may be weeks, it may be a few months. This is often a hard trajectory for a lot of patients and families because they're getting sick so quick, it's hard to wrap their hands around their illness. But then there is a role in here for palliative care. But these other 2 on the bottom here are very common disease trajectories, especially for our patients who have non-cancer illnesses. COPD, heart failure. On this side, on the frailty side, that's more of our dementia, our Parkinson's patients. You have a decreasing level of function, and over time you have these periods of where your disease flares up. You get sick, you get hospitalized. You have a lot of symptom burden. And then you kind of reset to a new baseline. Your function becomes a little bit less. Your symptom burden may become greater. Then you plateau out, but there's a gradual stepwise decline. And there's a big role in here for palliative care and what we can do and how we can help you understand the course of your illness. One of the big things I think we do in palliative care is give knowledge to patients and their families. We have those conversations about your illness. I start preparing you for the road ahead, what we're going to expect. So again, in palliative care, one of the things we talk about, I like to use the term effective forecasting versus something called prognosis. When prognosis, if I said, when you think of prognosis, everyone thinks of time, right? How much time do I have, doc, right? And I've already shared with you, we're not often very good at exact amount of time how patients have left. But what we are very good at is what I call effective forecasting. I know your illness. I know what may be some potential complications or problems that lay ahead. I may not know when those things occur. So for instance, if you're in your heart failure, my heart failure is filled with periods of time where your heart failure acts up. You end up in the hospital. What I do know is as those exacerbations become closer and closer together, something has changed about your illness. We need to change focusing about where you are in your illness. I don't know when those exacerbations are going to occur, but I do know they're going to occur. In our dementia patients, we know infections become a predominant problem in dementia. So when patients with dementia start having pneumonias, we know something has changed about your illness. I can't predict when you're going to have that pneumonia, but when that occurs, we're going to talk around it and what to do. So we prepare you for the road ahead about what to expect. So it's less about time, but knowing about what the disease may look like. Part of the thing that I hear from patients all the time is as you get sicker, you feel a loss of control. And then we as doctors often don't spend enough time trying to figure out how can we give control back to you. And I'll share with you, knowledge for most patients is control. If they know what to expect, even if it may not be what they're hoping for, but if they can prepare and understand and make plans and have those important conversations by giving control back to patients and allowing them to map out what they want from their medical care, it's amazing how it restores and reduces symptom burden. It reduces stress of the family. The family's now prepared. So it's a big thing we try to do. Again, my friend Dr. Myers has taught me this. Hope is success redefined. When you have a chronic illness that we can't cure, you know what? Cure is no longer the hope. What I'm hoping for is that you have a good quality of life. What I'm hoping for is you're free from pain. Or what I'm hoping for is that you have time with your family and can have those meaningful memories. So in palliative care, we spend a lot of time of what hope looks like and redefining it and moving away from cure and the miracle. Okay, people can always maintain and keep that miracle in the back of their head. I never dispel that myth because I believe in miracles. I can't define a miracle. I can't plan for a miracle, but I believe in miracles. But we look around and try to define success in other things that we can understand. And again, recognizing in palliative care that non-cancer illness creates the same amount of symptom burden as cancer. And actually, if you look at our non-cancer patients, the number of symptoms they experience in their illness is actually greater than our cancer patients, which is surprising. So the next two kind of go together. Palliative care means giving up, and palliative care means I will not live as long as I can. And they're kind of very similar. So I have to throw in a little bit of evidence-based medicine. That's the big thing we're trying to do now. So this is a big study that came out probably, 5 years ago now? In New England Journal. They did this at Harvard. And they took lung cancer patients, stage 4, which means it's not curable, and they got one of two things. They got their usual care, including all their chemotherapy, and the other group got all of that care, chemotherapy, usual care, but they got to see a palliative care specialist and a palliative care team to be involved as they're going through their illness. So here's what they showed. Patients who received palliative care had less depression, improved mood, better symptom control, improved quality of life. I don't like this term, but it's less aggressive care at the end of life, and I'll share with you what we define as aggressive care is they got less chemotherapy. They abandoned chemotherapy earlier, abandoned radiation treatments earlier for their cancer, and they live longer. And this just is a curve just to explain. This is a survival curve that we talk about in medicine, and these are the patients who got the usual care, and these are the patients who got usual care plus palliative care. So every stage along the way, with the intervention of palliative care, patients live longer. And by average, it was about 3 months in a patient population. With lung cancer, your average life expectancy at stage 4 is about 9 months, and with palliative care, patients were living out to almost a year. Okay, so significant difference of time. So, and I think what this speaks to me, what we do in palliative care is we have great and wonderful treatments. But as your disease progresses, what this tells me is the treatments become much more toxic, carry a lot more risk, carry less benefit. So it's those times as your illness progresses that we need to have meaningful conversations. Does this treatment really make sense for me? And for some patients, it really does. But for many patients, we've come to realize it doesn't. And they have better quality of life and improved symptom control Most people don't want to be in the hospital at the end of their life if you sample all the studies that have been done. But it's interestingly, 75%, 80% of patients want to be at home near the end of their life, but actually only 30% end up being at home at the end of their life. So there's some disconnect between that. So, and again, other studies have demonstrated that patients who receive hospice care, compared to the patients who don't receive hospice care, they live longer in hospice too, and have better quality of life. Again, I think it goes back to the symptom burden that a lot of our treatments carry at the end of your disease, near the end of your life. So that said, I'm going to wrap up. This is Diane Meyer, one of the palliative care thought leaders in the country, and she defines palliative care as this, is delivering care to the patients in the right place, at the right time, in the right situation. So with that, I'm done, and I'm open to questions.